You think about some of these treatments for cell therapies and gene therapies for really serious conditions that many thought were incurable for a long time. They're amazing. They're a beacon of hope for patients. They're an opportunity for cures in many cases, but they're one-time events. And so our health system that is used to amortizing that cost over a period of time is now being asked to pay for essentially a lightning strike event, an event that happens out of the blue for most, and that is a high cost event. And so we're wrestling with this idea of how do we be responsible in providing care to our employees while not being able to predict a high cost event. And for self-insured employers, smaller self-insured employers who may have budget constraints, it's a real problem.
Welcome to the Only Healthcare Podcast. Today, we continue our risk series with an expert whose career spans strategy, transformation, and access in life sciences. Joining us in this episode is Drew Wilkins, Managing Director at Monitor Deloitte. He's got 20 years of consulting experience and expertise in corporate strategy and innovation, and has a passion for access in health. Drew's going to help us explore how employers and commercial stakeholders can better manage risk, design benefits, and lead in healthcare transformation. So welcome to the Only Healthcare Podcast, Drew. And please add to this short intro and tell us about what areas are you spending most of your time on these days.
Randy, thank you so much for having me and for the introduction. As you mentioned, I've been at Deloitte for over 20 years now, and the work I do really does focus on access. It focuses on innovation in access, and it focuses on these emerging topics like cell and gene therapy and other high-cost therapies and ways that we can drive access for patients and for self-insured employers. I spend all of my time with life sciences companies and come at it from the biopharmaceutical lens, but have helped those biopharmaceutical companies really think about how they reach different patient populations and how they work closely with self-insured employers to drive access.
So let's spend a little bit of time setting the landscape. And if you can talk a little bit about how is the role of employers evolving in the healthcare value chain?
Over the last 10 or 20 years, as you and your listeners know, we've seen more and more companies become self-insured. And they've done that as a way to drive down cost, to take ownership of their employee lives and to be able to manage them in the ways that they see fit. But as we've seen the cost of specialty drugs increase, and as we've seen the advent of cell and gene therapies, products that can be into the millions for on a per patient basis, it's really challenged the landscape for self-insured employers. And I think those self-insured employers are really evaluating how they deal with these costs, how they make sure that they are maintaining their benefits, but also making sure that they're ensuring the viability of their company. And so, really thinking about the budgeting aspect and weighing that with the employee benefits is important. There's some great studies out there that talk about how when self-insured employers invest in their employees, provide them excellent health care, invest in these high-cost therapies that can be really transformational in patients' lives, employees are more loyal. And so there's a real business case for why self-insured employers should be thinking about covering these products. But there's some practical realities that I know we're going to talk about today that they need to wrestle with. Our healthcare system was designed post-World War II as a way to attract human resources and really to be a talent strategy. This was a differentiated benefit that employers started offering in a time when there was a war for talent. And that is the advent of our system in the United States today. Now, we are a long way away from medical care in the 1940s and 50s, of course, but the plans were designed to focus on a year at a time, to think about what the budget could or should be for employees over the course of that year, and then to help cover that cost. It is one of the only systems of insurance that isn't only for insurance. You think about your car insurance, and if your car breaks down, you don't call your car insurance company and ask them to pay for it. You call your mechanic, you call a tow truck. Uh, if you if you have a chronic condition that you know about, use your health insurance. Why is that an insurable event? Well, it just happens that that's the way our system was designed. And so it creates a challenge for employers in the world today as they think about the need to cover these chronic conditions, which, oh, by the way, are becoming more expensive and more common in our society, and also trying to think about truly insurable events, things like heart attacks, things like diagnosis of cancer. And so we're seeing a real balance between the kind of predictable things and the unpredictable in a system that was designed to spread costs out over the course of a year. You think about some of these treatments for cell therapies and gene therapies for really serious conditions that many thought were incurable for a long time. They're amazing. They're a beacon of hope for patients. They're an opportunity for cures in many cases, but they're one-time events. And so our health system that is used to amortizing that cost over a period of time is now being asked to pay for essentially a lightning strike event, an event that happens out of the blue for most, and that is a high cost event, much like, if a lightning bolt struck a tree, it would be a high cost event, it would be out of the blue. And so we're wrestling with this idea of how do we be responsible in providing care to our employees while not being able to predict a high cost event. And for self-insured employers, smaller self-insured employers who may have budget constraints, that's a real problem. And it's something that we've got to deal with and think about so that we can make sure that we're providing the best care and being, financially responsible along the way.
Just a question on that. How are they managing that now, right? Knowing that how you just articulated it was perfect. There's a big risk mitigation strategy that needs to take place in the budgetary side. So what do they do now, absent of any, major disruption, what they have?
Well, we've always had stop loss insurance and we've always had reinsurance. And those have been important tools for employers to use when things like organ transplants come up, things that you don't expect, things that violate, whatever budget thresholds you've set, and that you need to be sure to cover. And so stop loss has been a really valuable tool for many, many years for self-insured employers to be able to manage their budgets. However, as these events have increased and as the cost of things have increased, we've seen stop loss carriers appropriately increase the cost of their products. They are taking on more risk. The thresholds are now much closer to where the product prices are, the treatment prices are, and so they've had to increase their prices. That's put a financial strain on self-insured employers, and there aren't a lot of other tools available for them in the toolbox right now. And so we're at this inflection point in our healthcare system where we need to think about the toolkit, and we need to think about what other solutions are out there to help us continue to innovate, to compensate for these innovative therapies and innovative procedures that are on the marketplace.
Yeah, so perhaps your analogy about the car breaking down is similar to when you just go to the doctor for a checkup, or you go to the doctor because you have cough and cold. Like, why would you put that through your insurance, or why would you have your employer pay for that when really the more the significant events where there's protection is something that people should be thinking about, right?
If I get in a fender bender, I'm not calling my insurance company, right? If the cost to fix my car is $400 because somebody, I rear-ended somebody or I backed into the mailbox, I'm not calling the insurance company because guess what happens to my premiums? They go way up. If I get a cold, yeah, I go to the doctor. Yeah, I probably can't do anything, but I'll go get it checked out no matter what. It's exactly the right analogy. Now, I'm not in any way suggesting that we limit access to care. Like, that is not the message here, right? We need to find alternative ways to provide access to care. And, I think COVID is a really interesting example. We saw incredible innovation during that horrific period where we were all learning how to use Zoom. We also saw incredible innovation in healthcare. And, you saw rates of telemedicine increase. You saw reimbursement of telemedicine be acceptable. And we made the exceptions because of the extraordinary times in which we were living. I think it's a risk for us to abandon some of those innovations now that we are beyond the immediate part of the pandemic, and to stop looking for innovations. And so we need to continue to look for opportunities for us to solve the problems that exist in healthcare. And a lot of those have to do with financing. A lot of them have to do with how we think about this predictable versus unpredictable cost. A lot of them have to do with how we think about a plan year. I've had a lot of conversation with self-insured employers, and we actually recently published a paper talking about the future of healthcare financing. And we think one of the major constraints in our system today is that we price on a plan year. And so the choices I make as a plan, as a self-insured employer about your health are limited to that year. And so am I going to invest in all of the preventative care that you could or should or might want or need? Maybe not, because I don't have to worry about it until next year. So I'm pushing the ball down the hill. I'm waiting for that to come to fruition 3, 5, 10 years from now. And so, employers are really thinking about things like GLP-1s and obviously not for type 2 diabetes, but more focused on weight loss and some of the cardiovascular benefits that can be associated with GLP-1s. If I'm going to manage your life for 5 or 10 years, if you're a long-term employee and I have a long-term employee tenure in my plan, I might be more willing to sponsor GLP-1s for weight loss, because I know that there's a good chance you're going to be around. I'm going to be responsible for your type 2 diabetes when it comes up. I'm going to be responsible for whatever cardiovascular issues come up down the line. So let's get ahead of that and make that investment in our employees so we have a healthier and hopefully more productive workforce. If my employee tenure is 12, 18, 24 months, guess what? The decision looks a lot different, because GLP-1s are not cheap as they exist today. And so we're seeing employers start to trade those things off and think about that investment. Can we accelerate that by changing the time period in which we're looking at healthcare and health plans? If we all move to a 3, 5, 10-year plan window, I think we'd see some different choices being made by employers.
Yeah, that brings up a long-standing issue that I've always run into as well about this whole time scenario when you think about benefit design in the modern era. And you're right, all the rules went out the door during the pandemic just a few years ago, and we've kind of did a rubber band back to where we were at, which really wasn't working either. So we've been hearing a lot about direct contracting, reference-based pricing, bundled payments, on and on and on, with so-called innovations, things that we know we've been talking about for probably 3 decades now. So how do some of these innovations in funding that are being thrown around out there shift employer risk profiles? And is it good or bad?
I mean, every choice we make has consequences. And so it's really important that we talk about all of these and we have the robust dialogue about what the solution could be. And we make that problem a lot in healthcare, where biopharmaceuticals do one thing and it just squeezes the balloon on something else, or plans do something and it squeezes the balloon on something else, or PBMs do something. And so when I work on these innovations and when my clients come to me and ask me questions about how do we drive innovation in healthcare, I always go back to them and say, let's do this, but let's not think about it from the biopharmaceutical lens. Let's not think about it from the PBM lens. Let's think about our ecosystem, and let's think about how we align incentives. And I've done a lot of work on showing the benefits that can accrue to the ecosystem as a whole if you do the innovation the right way. And so one of the things I've been spending a lot of time on recently is a novel risk pool for cell and gene therapy financing models. And so what we've done is we've said, can we ask self-insured employers to actually carve out cell and gene therapy from their benefit design and take that risk and move it over here to a consolidated entity? And this is not a new model. There's been reinsurance over the years, but it brings it much closer to the self-insured employer themselves. And then what that new entity would do is to provide that coverage, because the patients need the coverage of cell and gene therapies. We are not saying carve it out and don't cover it. We're saying take it out of the pool and create a new risk pool where you bring self-insured employers together to create a larger body. That drives predictability and budgeting efficiencies, so that then I can say, instead of having to manage your healthcare costs like this every time one pops up, now I'm spreading it out and allowing you to budget. And I'm doing it on a per member per month basis that we can agree is affordable, and we can negotiate around, and we can understand the services that you're getting for that per member per month. And so I think it's really important to do things like that and to think about where those risk pools exist. You look at a large employer in this country, they've got a great risk pool, right? They're able to spread it out over 100,000 or 1,000,000 lives. If you look at a smaller company that happens to self-insure that maybe has 100 lives or 500 lives, it's too lumpy to be able to really focus on these high cost therapies. And so I think there are opportunities for us to innovate with models like that to be able to drive that coverage, but also that predictability and the sustainability to employers, because the way we're going right now is not sustainable.
So Drew, you brought up a really good point about you brought up the GLP-1s, which obviously is a major topic. And the thing that we consistently hear is that the employer's writing a check for $1,000 per month and getting a rebate 6, 8, 9 months later. These smaller companies, like you just alluded to, can't just carry those costs. And you work with manufacturers as well. Have you made any strides, or are they making strides in coming a little bit more full circle at more of a direct net price versus the rebate game, and especially in a place like GLP-1s where it's somewhat out of control. Obviously, there's a benefit there, but it's getting out of control.
I think there's a big opportunity to really think about our rebate model. And PBMs provide a really valuable service. I don't want to come across as saying PBMs don't provide a valuable service. They were created out of a necessity, a gap in the marketplace. And the pharma companies are the ones that created it. If you go back to the origins of the first PBMs, are the services that PBMs provide in line with the cost of the drugs today is the question that needs to be evaluated. And how do we think about what those rebate dollars are doing and paying for? And if you are the entities that are receiving those rebate dollars able to best deploy those to drive down the cost of healthcare? Those are the questions we need to wrestle with. But again, we've got to take an ecosystem view to this to make sure that we're thinking about all of the stakeholders that are involved here so that we can design the solution that is right to bring medical costs down across the board and not just squeeze the balloon amongst different players.
Your point is more readdress the rebate strategy, not necessarily get rid of it and just go to direct net pricing.
Again, I think we've got to think about all of the different entities that are involved here. And if moving closer to net price is the right answer, then terrific. But let's understand the ramifications of that choice across the board before we come out and just say that that is the only answer. I do think there's a major implication on the patients that we need to understand. And if you look at a drug that has a 50% rebate, the payer, the PBM, are getting the drug for half the list price, but the coinsurance and the deductible that the patient pays is based on the list price. And so the patients are being faced with a large out of pocket. They're facing cash flow constraints early in the year when the benefit design renews or when they get diagnosed and prescribed the drug. And I worry that prevents patients from being able to access the medicines that they need. And so I think an important part of any type of redesign is understanding what the patients are going to be responsible for and how to make sure that we're aligning incentives to meet the needs of patients.
So since we've been talking about rebates, what role should employers and the commercial insurance purchasing coalitions play in creating more transparency?
Our healthcare system is so complex. And even those of us who work in healthcare every single day, I think a lot of times don't understand all of the nuances of it. And so how do the three of us, if the three of us don't necessarily understand healthcare and all of the intricacies, how can we expect Joe and Jane consumer to understand how to manage their health? And health is such a personal and important thing for people to understand. And so anything we can do to drive transparency is going to do a few things. First of all, it's going to help people make smarter decisions about the care they seek and the care they use. Secondly, it's going to help us align across all of the different entities to make sure we're making the right choices for patients and for costs. And then third of all, it's going to help us have a more informed dialogue about it. And I listen to some of the things that politicians on both sides of the aisle say about healthcare, and I always cringe a little bit because it is so opaque. They're able to make an argument for whatever it is they're trying to do. And if you understood healthcare at a more nuanced level and it was more transparent, it'd be harder to spin it towards whatever your political goals are. And this is This is both sides of the aisle. So how do we drive transparency so that we can have the really honest dialogue in this country about what healthcare could and should be for our people, and make sure that we're helping patients be able to get the care that they need. And that is not to say that our politicians are not trying to do the best thing that they think they can. Frankly, I'm not sure they understand it to the fullest extent.
So let's shift back to more around novel therapies and the issues around health access as a risk variable. Since these novel therapies are high cost to ultra high cost, talking $1 to $5 million potential claims, so they're all catastrophic claims. Why must health access be factored into benefit strategy?
All of these diseases we're talking about for these cell and gene therapies have broader implications. They impact my ability to go to work. They impact my ability to care for my children. They impact my ability to generate economic well-being for, whatever it is I might be doing or responsible for. And even if it's not me, even if it's my child who needs one of these, it's pulling me away from work. And so there is an economic argument to be made for why we need to think about broader coverage of these therapies and programs to help with the affordability and the needs that patients and caregivers have as they go through it. That is, in my mind, the very basic but highest level argument for why we need to think about coverage. I also think it's important, though, that we think about the implications that these therapies have in terms of alternatives. And if you look at some of these diseases and the alternative costs that are out there and the costs that patients accrue over years and years and years of therapy, these therapies are actually cheaper than kind of the standard of care otherwise. And so we think about government programs, we think about Medicare, Medicaid, in covering some of these things. And I think there's an economic argument to be made about how we better manage the spending of those programs for some of these serious diseases. And then finally, these diseases affect all of us. And in my view, it is important that we are providing care to the people in this country and making sure that people can get access to the amazing innovations that our biopharmaceutical companies are bringing to the table here. But that requires we think about access. That requires that we think about these innovative programs and that we think about ways that we can make the economic arguments about why these products do make sense. Now, I get the question a lot around, why are these so expensive? Why is it $3-5 million for some of these therapies? And I think it's important that we think about how clinical trials are run. A lot of these are rare diseases, and so there are very few patients out there that can participate in these clinical trials. And so they're hard to find, they're hard to recruit, they're hard to treat, but it's critical that we do these clinical trials and we do them in the right way so that we can make sure the products are both safe and efficacious. But that's a cost that is borne by pharmaceutical companies. I think the average cost to bring a drug to market is something around $2.6 billion spread over 12 years, 10 to 12 years, with a probability of success around 10%. And so you think about the risk, you think about the costs that pharmaceutical companies are taking on as they move into these areas, and it's not insignificant. The second thing is, once you launch these products, they're hard to make. They're hard to manufacture, and they're hard to make sure that they get to the right patient at the right time. In some of these instances, they are taking cells out of your body. They are shipping those cells to a manufacturing plant where they are genetically modifying them. They're shipping them back, and then they're putting them in your body. And you think about the chain of custody that has to be perfect, because if you put the wrong cells in the wrong person, you'll have serious consequences. You think about the temperature controls that have to happen. You think about the precision manufacturing that has to be done. And so there is an incremental cost associated with these products for each individual patient, given the precision nature of the therapies. And so it's a very complicated system that is further complicated by the payer dynamics that we talked about at the beginning around our system is set up to amortize cost over time, not for a one-time lightning strike. And so we're having to innovate all of these things together to make sure that these innovative products also have innovative financing models to support them.
So there's, again, back to this balance issue of we need innovation, not only in the benefit design, but in the pharmaceutical solutions. We need good access, and we also need to be able to afford it, whether we're trying to develop these or we're trying to actually use these as a patient. So, what are some of the frameworks that you may be utilizing with your clients or you're thinking about to really bridge those three dynamics?
So I talked a little bit about the risk pool model earlier on, and I actually think that that is the most viable and feasible and probably desirable innovative model that we've come up with. There's some good analogs that are out there today. We think there's opportunity to enhance those to make the option more cost effective and to make it run smoother. But we think that that's a really viable model, and it's one that we're actively working on right now. I also think there's an opportunity for us to think about how we support patients and caregivers going through this treatment journey. And so I think there probably should be programs, much like supplemental insurance that you can buy today through your employer, that is readily available for patients to make sure that they can take time off of work, they can find the childcare for the rest of their family, they can support themselves while they're undergoing these, because the patients do carry a burden. Even if the drug and the administration of that drug are compensated, there's a financial burden those patients are taking on. And then I think we have to look at the buying dynamics of these products. And I think we need to look towards options for how companies buy these products. Are there ways that they can subscribe to them? Are there ways that they can essentially create futures contracts or options contracts to buy ahead of time that would reduce the cost because it creates certainty for the pharmaceutical manufacturer? But then, of course, you need to think about the secondary market that would need to support that. So if they're not used, can they be traded like futures contracts can otherwise? So I do think there's further innovation that we can go beyond some of these risk pool ideas. But I think the risk pool is probably the most timely and immediate one. I also think it's interesting to look at what's being done around from CMMI and some of the government innovation programs focused on sickle cell. And are they able to create some traction? Are they able to demonstrate that some of these models are effective in that population? And then how might that be emulated or expanded into other parts of the market to drive coverage as well? So we'll see where that goes, but I think we're all watching that one pretty closely.
Is there a specific innovation model you've seen, like a specific, in terms of inaction and it worked, right? Like a value-based model or something of that nature that you've seen that that you could point to when you're talking with your clients about that?
I think it depends on who you're talking with. I get a lot of questions from payers around warranty models. If I'm going to spend a couple million dollars on a patient, how do I make sure that this thing's actually going to work? Now, the data show that these innovations do work and they work pretty well, but it remains a question that companies are asking for. And so as we've gone down this path and companies have started to innovate in how they think about true warranty models, I think that's created some reassurance. I don't know what the utilization of those models has been. My guess is it's probably pretty low, but it is a confidence builder. These companies are willing to stand behind their products. Therefore, we as a payer believe we should stand behind them as well. I think we talked about stop loss insurance. I think stop loss insurance has been a great innovation. It's one that helped early on in how to cover high cost therapies, but we've seen that market continue to evolve as well to focus on cell and gene therapies. And I think originally when we started talking about cell and gene therapy, there was some hesitation around, am I as a stop loss company going to be able to really cover these things? And they started to pull back a little bit. But more recently, they've leaned back in. And we've seen them start to evolve the model, think about what the true cost should be. And then, we've seen the big payers start to innovate here as well.
Have they looked at anything around preventative, like pharmacogenomic testing? Is that something that they've taken into consideration?
I have not seen that. It's possible, but I have not seen that yet.
Just because it's, you could argue that that's a way to have a metabolic profile on a patient that the doctor can actually prescribe more personalized medicine, and maybe they're not, maybe they might be on a drug, the wrong drug for a year that's not working, but something like that they can get on the right drug.
Yes. I mean, we see that in a lot of the oncology products, right? Where we do tumor profiling to understand biomarkers, and that has been incredibly effective in figuring out should I be on product A or product B or product C to make sure that it's the most effective one for the patient. What I haven't seen and what I where I thought you were going and creates pause for me is, can I get ahead of any disease by doing genetic profiling? And then how does that change my coverage decisions? Like there's a whole range of questions about that that I think are worth evaluating and arguing about. Yeah, for sure. As we drive transparency and as we get better data, can we also start to look at the phenotypes of patients to align different therapies that match both the genotype and the phenotype? Now, again, fraught with risk that we need to evaluate and we need to be careful about, but does that provide us an opportunity to find the best therapy for each individual patient and to develop different products to meet needs in the marketplace where the indicator product may not be the right one or may not be working quite as effectively.
I guess the challenge is everybody's so used to thinking about value-based designs, and what we're really talking about is traditional medications and chemical-based products. We're not thinking about the biologics, which is a different game altogether. So to that point, how are we moving around this issue of designing for value in our commercial employee benefits? Is something going on? Is it stalled? Kind of what are you seeing?
I would like to see more focus on the value being created by the product. And I worry about additional Me Too products as the only way to drive down cost. I'd like to see cost more closely aligned to value created. Now, we got to think about the measurement. We got to find the right way to do that. But if we're going to drive value to our healthcare system, in my mind, you have to get to some sort of outcome or value or quality metric to be able to make these choices. And the Me Too's are fine as long as they create differential value. And if they are creating value for population versus population B, I'm okay with that. But two products that do the same thing and are just essentially the same molecule, I don't know that that's the best use of my innovation dollars.
What are some of the other either point solutions? We already talked about a little bit with diagnostics, but we now have AI to factor into the diagnostics as well as the treatment monitoring. What are you seeing in terms of some either just general trends as an evolution, or what's really disruptive that employers should be aware of or start tracking?
I mean, we can't have a conversation without talking about AI these days. So let's talk about AI for a little bit. I do hope that AI will change the way we do drug discovery and even the development work on some of these drugs. So I think there's early stage uses of AI that hopefully can start to bend the cost curve for what it takes to bring a product to market. Second use case is, how do we use AI to start to identify patients, identify them earlier, identify which products work best for which person, and to really shape the way that we're prescribing drugs. Now, we just talked about all of the risk of doing genetic testing, preemptive genetic testing. Those risks also exist with AI prescribing, and we need to be careful about bias that exists in these models as well. And we know that it does. These models are being trained on biased data, so not surprisingly, they're going to have some bias in them. So we got to figure out how to extract that bias or normalize that or make sure that we're being much more objective in these AI models they're being created. But my hope is that AI starts to drive down cost. I also hope that it starts to align on things like patient identification. And can we identify patients earlier on with diseases? Can we cut down the number of referrals required for some of these rare disease patients to get to diagnosis? Can we cut down on the number of prescriptions leading up to the actual one that works because we've got a better understanding of patients and of disease? And I think AI is going to be critical for that. I don't think we're there yet, but I think we're starting to see exploration in that space.
And now you've brought up what you're working on in terms of secondary insurance model, but are we also seeing anything happening around hybrid plans or looking at being a little innovative in plan types in general beyond just the catastrophic claim category?
My work has focused more on these high cost, ultra high cost cell and gene therapies, as well as kind of broader financing innovation. So I think that I think that those two topics are critical for self-insured employers. But I also think that we need to continue to evaluate how we're designing plans. And can we look for those longer duration policies, for example? And self-insured employers have an advantage there. They have the opportunity to work outside of some of the guidelines to be able to do that. Can we look for the ways that we're creating novel mechanisms to support this insurance versus the predictable cost? And one of the ideas that we have is, could we move to more of a savings-based model? Think your HSA or your FSA, but more of a savings-based model for things that are predictable. If you're a type 1 diabetic, guess what? You're going to buy insulin next year. You don't need insurance to tell you you're going to buy insulin next year. And so, instead of paying an insurance premium on the probability that 100% probability that a diabetic is going to buy insulin, could we equip that diabetic with some sort of savings to be able to cover that and to make the choices that are right for his or her care? So I think there's some opportunity there. And then I think there's opportunity to think about how we make sure that we're reaching some of these deserts, these healthcare deserts that exist in this country. And we talked about COVID and we talked about telemedicine early on. How do we make sure we're continuing to invest in that? And how do we make sure that we're bringing these complicated drugs in these deserts as well? Because to administer some of these more complicated drugs, and I'm not just talking cell and gene therapy, I'm talking even some of these biologics, are there access to infusion centers, for example? Are there access to diagnostic centers? Can I get the specialists that I need? And how do we innovate the care delivery model to make sure that we're bringing care closer to the people who need it?
One more question about the collaboration or lack thereof between the employer purchasing coalitions and manufacturers, as an example, around this issue of accountability. So if they come up with some of these new models, how do they help keep each other in check and accountable to the patient?
I think it comes down to transparency. How do we be transparent about the models that we're creating? If my employer is part of a coalition and that coalition decides to launch a new program or a new plan, it should tell me what's in it. It should be readily available. It should be clear that it is committed to reducing cost, improving care, whatever the guiding principles are. And I should know that because it's my care that we're talking about here. And if we're really trying to do the right thing, you shouldn't need to hide behind something that, shouldn't need to hide behind your innovation to be able to do that. And so I would hope that anyone who's really serious about bending the cost curve and providing transparent care is willing to stand behind those principles and bring them straight forward to the patients and members they serve.
Well, this has been a really great discussion, timely, but also in depth. We're tackling a lot of topics too, but very, very much important ones and lots to think through and really lots to innovate on, as you know. So just, Drew, wanted to thank you for sharing your time, your expertise, and obviously your big picture thinking with us today. It's clear that managing risks in employer-sponsored healthcare isn't just about the cost. It's about the responsibility, strategy, and leadership. From access to innovation, funding models, as you discussed, this conversation laid the groundwork for a very intentional and sustainable future and benefit design. For our listeners, if this episode sparked new ideas or challenged you to think, we invite you to subscribe, leave a review, and share this conversation with your colleagues, as well as other topics you might want to hear. For more content like this, head to theonlyhealthcarepodcast.com and check out our full risk series. Until next time, keep asking bold questions, seek real solutions, and building a better path forward in healthcare. Thank you all for listening.
Thank you for tuning in to the Only Healthcare Podcast. We hope you found today's episode insightful and informative. Remember, our mission is to provide actionable and inspirational insights on how we can improve healthcare cost, care, and accessibility for all. If you enjoyed this episode, please subscribe, rate, and share with your friends and family. For more resources and updates, visit us at onlyhealthcarepodcast.com. We'd love to hear from you. Let us know what topics you'd like us to discuss in future episodes. Until next time, stay informed, and together, let's navigate the journey to better healthcare.